Today is appendicitis. You have to know this. This is high yield information. This is so common. You probably know a friend that already had the appendix removed. This would be nice to kind of understand the pathophysiology behind it. Let's jump on the bandwagon. The first thing I want us to go over is the definition, right? This is the appendix in this picture right here. And if we break the word into two, appendicitis is the inflammation of the appendix. Very simple, but it's not that simple. Let's find out exactly what's causing it. Now, before we talk about the causes, let's go over the anatomy. Now, people really most people kind of know what the pain feels like. So everybody kind of understand what the pain of appendicitis, right lower quadrant pain, periumbilical kind of radiating down to the right lower quadrant. But let's really focus on the anatomy. So here's your ascending colon. I kind of cut off the ileocolic junction over there. But here's your cecum, and that's the appendix. Now, I want you to see something. This is the belly button, right? That's the periumbilical area. And I just drew the spinal cord because we're going to talk about pathophysiology. But before we go into that, now that I've seen where the appendix is, usually in the right lower quadrant of the belly, what could cause this? Well, the first thing you want to know is lymphoid hyperplasia, which is basically lymph nodes that are swollen. The hyperplastic lymph nodes. They obstruct this guy and they cause venous congestion. But before we go ahead, the next thing that causes it, fecalith. Hard poop, right? Gets stuck in there. It's number 2. Number 3, tumors. Carcinoid. Carcinoid tumors are serotonin producing tumors, right? They cause flushing, diarrhea, wheezing. You know, we're going to talk about them someday when we go over another lecture. Foreign bodies, right? You swallow a huge coin, it goes through the bowel, and accidentally drops in there. Not too good. But the most common ones you want to know are these top 3. Okay? Now that we know what causes it, I think understanding the pathophysiology of what causes the symptoms of appendicitis is extremely important. That is the importance of drawing this picture. Now, the first thing that happens initially, it's the organ problem, right? The appendix. That's why the pain actually doesn't start at the right lower quadrant. It's going to start periumbilical. Why does it start periumbilical dull pain? Look at this afferent fiber supplying the appendix. They pick up the nerve sensation and they jump on the wagon by crossing with the T10 sympathetic nerve that synapse and go into the spinal cord. And these guys send efferent signals at the level of T10, and that's why patients always start with periumbilical pain. It starts around the belly button. It hurts. That's why it's the T10 sympathetic nerve. T10, T pain, right? T pain. It's because of the sympathetic nerves that go together with this afferent fiber supplying the what? The appendix. They go into the spinal cord and it kind of cause this dull, aching periumbilical pain. That's where it starts. But however, as the appendix starts to get inflamed bigger and bigger, right? The inflammation, all of it sudden start to rub on the peritoneal cavity. And eventually the skeletal muscles, right? The rectus abdominis, the transversalis muscles, the oblique muscles, they get inflamed, and then it becomes right lower quadrant. Now, because now the inflammation is so much, it transmits to the wall. It's transmural inflammation, and there you get right lower quadrant. That's why you get the periumbilical pain transmitting down to the right lower quadrant. That is the pathophysiology. Now it's more localized, it's more intense, it's very painful. That is the pathophysiology of appendicitis. Isn't that cool? I think that's cool that you know that. Now you can go and shine and explain to people that this is actually a visceral which means organ, somatic, reflex pain, because it starts with the organ first, but the organ is not inflamed to the point it's touching the skin. It's just inflamed so that the pain fibers are able to pick it up, and the afferent pain fibers from the appendix accompany the sympathetic T10 trunks, goes into the spinal cord and causes inflammation around the T10. The efferent takes it out, and that's where the periumbilical start. And now it becomes somatic, which is body. It goes to the body after the inflammation is bad enough to inflame the peritoneum and also the skeletal muscles, the parietal peritoneum. And that's why we get all this. Very easy, isn't it? That's my job. So we talk about the definition, we talk about the causes, we talk about pathophysiology, let's talk about history. What are these patients going to present with, right? I told you already. Periumbilical pain, eventually going to the right lower quadrant. Nausea. These patients are vomiting. Right lower quadrant pain. Where exactly is the point you need to know for boards, and for the wards is this point. 2/3 of the way down here is called the McBurney's point. That's usually where the pain of the right lower quadrant pain is localized. Nausea, vomiting, right lower quadrant. It lasts for hours. It's kind of dull in nature. Sometimes it's sharp. Now, this is one thing you're going to notice. These patients don't want to eat. They have anorexia. So it's right lower quadrant pain, which usually start periumbilical first. They have nausea. They are vomiting. Now, if the patient says, I want to eat a food, you want a sandwich? That's called the hamburger sign. No, that means it's not appendicitis. So that's how we fool patients. When I walk into the room, I'm like, man, do you feel like you want to eat anything? They're like, yeah, I would like a scrambled egg right now. Oh, okay, now that's not appendicitis. That's called a hamburger sign. But if they have nausea, vomiting, they're going to be anorexic because they don't want to eat. They have loss of appetite. So you want to know that. Now, on physical exam, they might have some slight fever also, so you want to keep an eye on that. They might have a low-grade fever, but usually these are the most common symptoms. Now, on physical exam, what do you want to do? There's a couple of tests you can do. Something called the Rovsing sign. And the idea of the Rovsing sign is you push on the left lower quadrant of the belly and you push down, and if pain is elicited on the right side, so you push on this side and like, do you feel pain here? Yeah. That's a positive Rovsings. These tests are not specific or sensitive enough, but if they do come back positive, it's very specific for appendicitis. Now, another test is called the obturator sign. Now, in obturator sign, let's have the patient lie on their back. Okay, this is the bed, and the patient is lying on their back. Okay, and you take their leg and you cross it to the other side. I'm not really drawing this well. Basically, you take one of their legs and you cross it to this side, and when you cross their leg to this side, you push away, right? You push away and you tend to push in. You try to adduct, it's going to elicit pain around the psoas because the irritation of the psoas, that's going to hurt like a son of a gun. So that's a positive obturator sign. The last one, but not the least, is the psoas sign. Psoas sign, you have the patient lay on their back, right, on their butt, and you tell them to raise their leg as high as they can, and you push down this way, and they resist, and they feel a lot of pain in the right lower quadrant. That's a positive psoas sign. So those are the three signs you want to check to make sure they might have appendicitis. You want to push here at the McBurney's point and let go and see if they have rebound tenderness, because that might be a really bad sign if they have a rebound tendon, but they will definitely have pain in the right lower corner when you push. If they have rebound tendon, they might have perforated, and that is bad. You don't want to have a perforated appendix. So if they do have perforation though, their vital signs are going to be unstable, right? Because if they perforate peritonitis, they get into sepsis, they have hypotensive, tachycardic, they have a lot of high white blood cell count. So that is a serious complication. Now, the only issue we run into in medicine is children, immunocompromised, pregnant patients. These patients, they have a retrocecal appendix. The appendix is always at the back of the cecum, so we miss it. Problem is we miss those, and this can make these people die. So you want to make sure you don't want to miss this in a lot of these patients, because they have a typical presentation. How do we diagnose this? Now, this is one of the disease process that you as a clinician has to have a clinical suspicion. Guess what? It's a clinical diagnosis. Trust me. You diagnose it clinical with all your hands and all your knowledge. By the science, the history, and the physical exam, it's a clinical diagnosis. But if you can't diagnose it clinically, you can order some tests. You can order an ultrasound. If you order ultrasound, you take a look at the area. You try to see if there's loss of the psoas shadow. If there's loss of the psoas shadow, that's giving it away. They might have appendicitis. Now, another thing, because the psoas is all the way at the back here, right? Coming from the, if I have to draw it out, the psoas comes out this way. It's going to run all the way and attach to allow you to be able to flex your leg. So the appendix might be sitting over there and causes inflammation. If you put an ultrasound machine, you're not going to be able to see the psoas shadow. So it's kind of called the, you can do an ultrasound. And actually, I'm sorry, I take that back. That's a KUB test, which is the kidney, ureter, and the bladder test. The ultrasound will be able to show you an enlarged and non-compressible appendix. If the appendix can be compressed, that's telling you you have appendicitis. And we can order a CT scan, which shows what? Periappendical stranding. So that's one thing you're going to notice on the CAT scan. And the CAT scan is the most specific. It can actually show you what the appendix looks like. And the appendix is always large. It has a lot of fluid, right? Inflammation causes a lot of fluid around the area. So now let's talk about treatment. How do we treat these patients, right? It's a clinical diagnosis, but you can still use all the diagnostic studies to try to diagnose this. On labs, you're going to see a lot of white count, right? WBCs, high white count, around 11,000 to 15,000. That's usually what their white count looks like. Before we forget, we have to order labs, right? We can't just jump straight, without seeing if you actually have an infection. Another thing it also comes with a left shift, which is basically neutrophils shifting to the left, like banding, a lot of neutrophilic infiltration. So you want to keep an eye on that. So another thing you want to order is a urine. Get a urinalysis. You might see some red blood cells and some white blood cells. And the reason is because this inflammation can affect the ureters coming from the bladder and cause a little bit of white blood cells in your urine. So that's another thing you can also use. But otherwise, it's clinical. It's really not much you can order than that. So treatment-wise, how do we treat this patient? You want to have bowel arrest, right? You want to keep the bowel from eating. MPO, they're not eating anything. You give them antibiotics. The antibiotics we give is cefotatin. That's what you want to give them for antibiotics. Also, you want to give them a lot of fluids. IV fluids, bowel arrest, antibiotics. And because this is appendicitis, you're not going to let them go home. You're going to call surgery. And you're going to get a laparoscopic appendectomy, which basically means they take a couple of scopes, they go to your abdomen, they go in there and they cut it off. And they cut this piece out, and then you get an appendectomy. And that's the only treatment you can give for you. You take it out. right? You're not gonna send them home. There's no way you send them home on this because they can perforate, which is one of the severe complications of appendicitis. So you want to watch out for that. That's extremely important. If they do perf, cover them with a lot of antibiotics and continue to check their white count to see if the white count actually goes down. All right. Another thing that can actually develop is an abscess. You can develop an abscess after the surgery, and you have to go in and drain it. Okay. So we've talked about appendicitis. It's very important that you know it. It's always common in people between 20 and 30 years old. So young adults always get it. More common in also males. So that's another thing you want to remember. So between 10 and 30 years old patients. So the young generation are going to come into the hospital coming with all this complaint. And we'll talk about the definition, which is an inflammation, right? Right periumbilical, right lower quadrant pain, okay? Nausea, vomiting, they do not want to eat. If they say they want to eat, think of something else. It's not appendicitis. Okay, it's clinical. You only take care of it by surgery. You do a bowel rest, MPO, make sure they're not eating any food. Give them antibiotics to cover gram-negative, a lot of fluids, and you have to take the appendix out to a laparoscopic procedure. All right, that is the end of our lecture. I hope you enjoyed it. Thank you. Hey, thank you so much for watching the video. I hope you learned a lot. Are you studying for the USMLE Step 1 or Step 2? Are you studying for the NCLEX or you're currently in nursing school as a nursing student? Are you a PA student currently in school or studying for your PANCE exam? Or are you a nurse practitioner student or trying to take your NP board exam? Listen, I've got super awesome content for you. If you truly love this video and it simplified your learning process, I want you to check out my website below. I've listed all the list of exams, whether you're studying for any of this board exam, and all I want you to do is click on the link right now below so that you can take you directly to my website. For USMLE, just go to smashusmle.com. For NCLEX, go to crushnclex.com. And if you're studying for the PANCE exam, the nurse practitioner exam, or you're studying for your internal medicine board exam, just click below and it'll take you directly to ftplectures.com. Listen, I can't wait to help you. If you need to get in touch with me, just get to my website, you're able to reach me directly, and we can work together one-on-one. Listen, you're super awesome, and my goal here is to help your dream come true. If you want to be a doctor, want to be a nurse practitioner, a registered nurse, or physician assistant, I'm here to help you get to that next level. With your medical knowledge, let's save the world together. I love you guys. You guys are super awesome, and do not forget to click on the link below to be able to get to my website. Also, don't forget to subscribe to my channel. You guys have a great day. Let's go.